Awesome. Well, thank you very much. Jacqueline and I started engaging with one another, I'd say about 3 months ago, and it's been a terrific ride since then. And she's made many, many introductions for me, including allowing me the ability to speak in front of you today and to present our story and also to ask for your help. So, my request today, before I even start, is that as you listen to my presentation, and think of questions you may want to ask us, please think about your community that you work in and or other communities that could use healthcare resources that actually scale clinical resources and also do really, really high touch engagement within patients. So that's what I'm looking for from you guys today, is really connections back into Alaska so I can work with remote citizens who really, really could use the support that we actually provide. And like Jacqueline said, I've had many years that I got to work in Alaska. My original work there was with the VA when I was lucky enough to put together the VA's telemedicine program out of Vision 20, and then, of course, up into Alaska. And I think I shared with some group that I feel very fortunate that when I was there, we got to give the first $1 million to Afghan in order for them to start their telehealth network. So a lot of pride in that, and it's a great, great organization that's done really, really good things over the years. So then I spent 13 years working in Alaska with several different companies, mostly working to build video conferencing capability in education and in healthcare delivery. Super exciting. Love you guys, love your space. And I just feel so fortunate to get to understand what Frontier America looks like, works like, and the real deep need for support and healthcare resources in spaces that people just simply don't necessarily have the access that they could or do in certainly urban areas in the continuous states in the US. So I've got a simple presentation for you. Let me go through that. And then my hope is that at the end of that, I'm just simply giving you some insight. At the end of that, I really want to read a case study about one of our patients. And it wasn't Jake. Who was it that I saw behavioral health? Jerry. You'll probably be particularly interested in this use case because it's a behavioral health use case. So let me present, and then I look forward to addressing any questions that you guys have. So my company is called Welcome Home Health. We started in 2015, and we are really in the care management space and the space that looks at how do we connect appropriate patient care and reduce the gaps of care that we see out in the environment. And our premise really was, can we build a health support system that provides patients access to healthcare services 100% of the time and have clinicians spend 99% of their time on direct patient care? For those of you who are clinicians, you live this every day and you know that you don't get to spend 95% of your time working directly with patients. The other thing I know on the back end of that is when patients have left your clinics and are at home, they and their caregivers very often have questions, they have needs, they need support. And my company has really come in to close that gap and really help patients with answering those questions using the care plans that you guys gave them, helping address those questions, and then ultimately reaching out to you on the patient's behalf when we can't fully address the question. Again, with that in mind, you know that when a call comes from myself or my health advocate, that in fact, it's a really credible call that's been vetted out, that does need clinician input. And then I can get right back to that patient within minutes of talking to you to really support their need and help them stay timely with their care and timely with their recovery. So what we put together is a fully integrated care management solution. I use health advocates to engage with patients. We set up a program that's available to patients 24/7. As much because I look at it and I say patients are sick on the weekends, patients are sick on um, after hours. And then patients are also sick on holidays and they need attention during those times. So I said, if we're going to put a program together to really be a hand holding support system for patients, then we need to be there when they need us. So 24/7, one of my health advocates will always pick up phone or video and engage with the patient to address whatever need they've got at that moment in time. Our model is really set up so that we follow care plans that the provider has given to the patient. That gets put into our patient health record. And whenever our patient health advocate goes in and works on the patient's health record, or the patient has a question, they will key information into that health record. If the patient needs clinical attention, again, we're a rapid conduit to the patient's clinical team. And then I would really think of us as a hybrid digital health and human engagement model. So we're very, very much about digital health, both in that we use video conferencing to always engage with the patient. Unless the video conferencing is not working, then we go back to a telephone. We capture data both through Bluetooth and through engagement with our health advocates. And then we use that data that we capture to really foment information back to the clinical providers on how we can help providers send their patients out to be more successful in their recovery processes. I built this model to be scalable. It occurred to me after being in telemedicine, 15 years at that point, that one of the things that was really missing is a consistent program for patients to get the support and services that they need, and also something that's just scalable across telehealth programs, across clinics, across states, and across the whole United States. So when we started, we very much wanted to be proactive with our support of patients, but we also wanted to make sure that this program could easily be scalable and configurable so that at the clinician level, we can support the clinician the way he or she wants to support their patients. And then at the systematic level, we've really got a pretty systematized approach that will bring data to the bottom line to, again, ultimately inform how we can all better take care of patients in the gaps. So we're configurable. We also stratify patients to get them to the lowest cost care solution for care disposition. This generally is around inpatient health, and we will look at patients that very often in the past have gone to SNFs for support or LTACs, and with a Welcome Home Health in the game, we can actually take on lower acuity patients who are going to the SNF for a myriad of reasons, but not necessarily because they really needed to be in the SNF for a clinical reason. We incorporate program analytics and give providers insight into their patient and their patient cohort activities. Again, very much around how do we change healthcare and healthcare delivery, and how do we really impact access and reduce unnecessary utilization at the same time. Key value in analytics, we really pay a lot of attention to reducing unnecessary utilization. We are an end-to-end solution. So when we engage with the patient, we start engaging with them from either their clinical visit or their discharge from the hospital, or a caregiver at the home who says, we're going to add this service on for you. That person actually introduces the patient to us, again, over a video conference. My health advocate welcomes them aboard, visits with them, generally 5 to maybe 7 minutes, answers their questions. And then after that, we schedule daily visits with the patient, at least for the first 2 weeks when they've onboarded with us. We go over care plans with them. We schedule appointments for them. We also require that within 24 hours of being on board in our program, that they have a comprehensive medication reconciliation completed, which is done by our team of pharmacists. I'm not going to read all of this, but this just gives you a place showing you our high touch patient engagement model, and then also just giving a sense of best patient use cases for us. I would not say this is a comprehensive list. I would say this is a best list of things that we've already done, and places where we see that there's a real need for patients to have support. Again, our model, our high touch model is, we believe that one of the things that's missing in healthcare delivery today is just that high touch engagement with patient. We speak with them, I say, in plain English and or their plain native language. We do daily visits for at least the first 14 days while they're getting used to engaging with us and being part of our process. Every patient has to come in with a care plan that we help them complete and really complete towards on-time recovery or staying within the paths that they're supposed to stay in for their chronic conditions or other issues that we may be working with them on. We've also set this system up, as I shared, 24/7. They have access to our patients with triage to clinical resources all the way to 911. So when I first started this model, I was very fortunate that the AMR, the ambulance company in Portland, was willing to work with us. So they actually brought us in-house, taught us how to do dispatch, and really taught us how to engage all the way up to 911 with patients. So we feel incredibly comfortable doing that. We also ask our patients, whatever their issue is, to call us first, and we'll do the triage and we'll call out and bring in the right resources that they need. And again, that includes all the way to 911. I thought I would tell you a few patient stories just to give a sense of, how we engage and what we do and what that really looks like, because that's really the crux of Welcome Home Health and the crux of our model and why patients actually do engage with us. So Pat's story is one of health issues all of her life. She had difficulty really just staying on top of the medications that she was required to take because of her health issues. And ultimately, she was in and out of not only hospital a lot, but she was a high utilizer of emergency departments. When she came to Welcome Home Health through a primary care provider, they really asked us to work with her to help stabilize her understanding of her medications, to help her get her medications on time, and then to also just really help her with some basic health skills and daily life skills. So we did that. And one of the things that we did with her was we really put a routine in place for her around her medications and taught her how to do that. And ultimately, her response is she feels like she wouldn't have made it without, the resources that we gave her. As we occasionally check in on her, she's still doing well with those resources that we gave her and with the information we taught her. She was in our program for about 9 months. This is almost my favorite story because Hank was our very, very first patient ever. And Hank came to us in New York City, where we were lucky enough to put a program together, really looking at, could we close a loop and make a difference? And the loop that was closed was working with a home health aid company, working with a physician group in the city that had ER facilities across the city, and then also connecting into the hospitalist team at Beth Israel. So Hank was our first patient. He unfortunately had a homemade nurse because he had recently lost his wife. He lives alone, and he has diagnosis of AMI and high blood pressure. His longitudinal care support, which is what Welcome Home Health considers it does, was for weekday check-ins. After a while, we learned that many of our patients don't like weekend check-ins because they feel like that's their their time, and they feel like sort of their work and paying attention to their health is a weekday process, not a weekend process. We acquire biometrics, and we can either do that through Bluetooth, or we can do that by actually asking the patient to take their biometrics and then report them to the PHA during every one of our meetings. We confer with their physicians, or conferred with his physicians when clinical thresholds were exceeded. And then when he was going to his regular physician visits, we would send in our reports for him. And they were actually concise reports, so they were usable to the physician, not just a bevy of information that ultimately was going to be hard for them to go through and not easy to synthesize. And then the homemade nursing team wanted weekly reports on how he was doing with his ADLs. Then we were to engage with the family as needed. I think the best part about my story with Hank is that he was still active. We had him at 94 for 3 years, still active, went to museums, attended plays. And then I say he's a self described dinosaur because one of the stories that he told me very early on was that he was more than willing to help us out, but he just had no clue about how to use technology, even though he had been a business leader all of his business career. And it was a very wonderful day when he told me that, because I was there teaching him how to use video conferencing, which he had never done. And the moment that the health advocate got online, his face turned into the face you see in this picture. And he was absolutely delighted. And he goes, Vanessa, I'm a dinosaur. I don't know that I can use this. I don't know that I can make this work. And so I had built a one button push into the tablet technology, so they'd be really easy for seniors to use. So 3 different times we got on, we pushed the button, got the health advocate, and worked it. And then the final time he pushed it by himself, and he just again got the biggest grin, and he goes, okay, I can do this. So, that's just part of how we engage with patients. And it's delightful for them, it's delightful for us. They end up trusting us, which is why the conversation keeps going. And it's also the reason that they call into us when they need help. 33% of all calls in our system are inbound calls from patients. So my final use case I wanted to do is I actually wanted to read, this is Gabe Story, and I actually wanted to read from notes that my team had put together for me about him. And I just thought you guys might find this interesting. And again, it gives you a sense of the value of the health advocates for the clinical team. Gabe came into our program as a result of being hospitalized at a local children's hospital because he was experiencing sleep disturbances and visual hallucinations. Within one day of being in the program, Gabe set an alert with a severe anxiety attack. He complained of something touching him and something looking at him through his window. Our PHA proceeded to walk Gabe through some relaxing techniques, and as a result, Gabe de escalated and went back to sleep. Over the next several months, this would be a typical call and process for our PHAs. The PHAs would calmly walk through several techniques provided by the therapist, ultimately ending in the client going back to sleep. As a rapport began to build between Gabe and the PHAs, he began to trust our team. He would often call them by name, and the calls would begin to increasingly not be so urgent. He would calmly explain what the situation was, and sometimes even request what relaxing technique he would like to do this time. Gabe would listen as the PHA would walk him through the next episode. He began to share his likes and dislikes, often talking about Pokemon or Fortnite for several minutes. The PHAs listened and inquired about his hobbies and activities, all the while ensuring that the client felt understood, comfortable, and more importantly, safe. The urgent 3 a.m. calls became less frequent as Gabe continued his therapy and daily check ins with the PHAs. The therapist and the client worked on the 10 written steps, which were steps that the client could use on his own to de escalate. PHAs would remind Gabe of his written steps and oftentimes would go through them during check ins or on the now occasional alert. The client became more confident in his abilities to de-escalate himself, partly because of the PHA's work with him all of those nights. The family reported that empathy, patience, and consistency provided by the PHAs resulted in Gabe being able to work through his sleep disturbances. They were thrilled and relieved. After several months, the night calls had all but ceased. The client appeared more happy and even a little too busy for the check-in calls, which we always think is a good sign, because when people start getting too busy for our calls, it means that they're moving back into their regular life and not so focusing on the issue. So that's always a key sign for us. The PHA saw a definite change in his demeanor. He was spending more time doing the things he loved. Gabe was also appearing less tired as he was sleeping through most nights. After 10 months, Gabe was discharged from the program. At the time of discharge, the client and his parents reported that the client was doing very well. And I would just say that's a very, very, very typical outcome that we have with Welcome Home Health and with our patients. So my last slide really is my ask. Introduction to programs that provide after-hours support for individuals with disabilities is one area that we're looking at. And another one, I used to know Native corporations, but don't so much anymore. And I would be interested in talking to Native corporations who are doing it at-home senior care.
That was fantastic. Thank you so much, Vanessa. This is a perfect opportunity to hear from our audience and see if there's any questions. I have some, of course, as always, but I'd like to open up the floor. Is there anyone who would like to ask Vanessa about Welcome Home Health?
This is Yvette with Frontier Community Services.
Awesome.
Hey, so just curious, is this, what is your billing structure? Do you accept Medicaid, or is it private health, or how are you funded?
So we have set up a model, having been in telehealth for lots of years and knowing lots of funding methodologies don't work very well. We have set our model up to be a B2B contract model. So I'll contract with whichever system wants to use us on behalf of their patients. And then we will, if you guys bill Medicare, Medicaid, if you guys bill insurance, we will set up all the paperwork appropriately so that the work that we're doing with your patients is billable, and then send that information to you so that you can ultimately bill for our services.
Great, thank you.
Mm-hmm. Some great question. Any other questions? So maybe building.
I have another question.
Yes, please.
Yeah, so are you looking to get into rural remote Alaska, like Western Alaska, or what are you looking for?
You know, I would, I think that the only difficulty we're going to have is that, and caveat, is that my model is set up to use cellular technology. So if cellular is not available in a remote or frontier area, then it's gonna be difficult to engage with us. But if it is, anywhere.
Awesome. Yeah, most of rural remote now has cellular capability, which is fantastic. I mean, it's new within the last 5 years, but we're really doing well there.
Well, and the reason I went cellular was because I knew we wanted to scale, and I knew broadband was going to require that we would have to support broadband and also likely go to patients' home to help set up the equipment. And it just wasn't a scalable model. So when I was looking around at that point, again, 10 years ago, cellular was good enough to go ahead and start using that modality. And I've been really pleased with it thus far.
Sure, that makes sense. Thanks again.
And it's pretty inexpensive as well.
Awesome. So if anybody would want to, if you want to put your contact information in the chat again, we'd be happy. I can share that with Vanessa, or if you need Vanessa's contact information, just please let me know. Building on those questions is, I know you and I have worked together, Vanessa, to look at whether this service that you provide could help the direct support professionals in Alaska. So maybe speak to that specifically for a moment.
I would look at Welcome Home Health most often as a extended service model, and one where we could help clinicians, we could help nurses, we could help folks in the home extend care into after hours, weekends, overnights, so that the care provider can actually have some breathing space and know that the patient's going to be taken care of at the highest level. They would take care of them themselves, and then they would get a call from us only if it really was something that we had all agreed to and it was really out of threshold concerns that needed to be addressed in that moment.
Excellent. And we're still working on that. Some of the health tie projects take months, even sometimes a couple of years to develop, but that is a relationship that's ongoing. Are there any other questions that people have for Vanessa?
I'd love to ask a few questions.
Please.
Okay, so my question would be, again, it's been a little while since I've worked in Alaska, but I think things are probably still somewhat the same. Does a model like this, in your mind, make sense in Alaska? And or if not, advice on shifts that we could make to make our model more workable in a rural/frontier setting?
Great question. And I know that sometimes you've been asked to come in and provide behavioral health services. So, Jerry, I'm going to call on you directly, or maybe others in the.
Sure.
Please, can you tell us whether
Sure,
you
I
think?
think the model. Yeah, I think the model works. There's some other examples. BHR out of St. Louis does some supplemental work for behavioral health providers, doing assessments and helping people access services. The key is getting the relationship with the organization that you're going to be an extender for. And as you know, in Alaska, it's all about relationships. So it's finding those that would be willing to adopt you, if you would, as an extender in their network of providers.
Boy, I totally agree with you on that. And I think when I first started working in Alaska, I went up there continuously almost for 3 years before, the business actually started coming my direction. Like it's very much, and rightfully so. Like, I think our healthcare is a relationship business anyway. And knowing that somebody from, the lower 50 are going to come in and help you out, they have to prove that they're going to be there and support and get it. So yeah, it should be that way.
Awesome. Well, Vanessa, that was a wonderful presentation. We have an ongoing relationship with you, and I look forward to sharing any of these contacts that come through my email, and I'll be following up. And I want to thank everybody who came today.